Imagine you're just lying in bed,
Hmm.
completely still, and suddenly your blood pressure just skyrockets to these stroke-inducing levels.
Right.
Your heart drops to this dangerously slow crawl, and your head feels like it's literally about to split open from the pressure. And the trigger for this massive, life-threatening crisis isn't a heart attack. It's not a severed artery. It's literally just a wrinkled bed sheet.
Yeah, a wrinkled sheet pressing into your leg.
Right. And your body's internal alarm is just screaming, but your brain is completely disconnected from the siren, so you can't shut it off.
It's a terrifying reality. I mean, we're talking about severe neurological disruption here. We
Hmm.
go through our entire lives like taking the internal machinery of our bodies completely for granted.
Oh, absolutely.
You shift your weight in a chair so your skin doesn't get sore.
Hmm.
You cough to clear a speck of dust. You sweat when the room gets too warm. All of that is happening invisibly, managed by this high-speed biological network that literally never sleeps.
But when that network goes offline, whether the central cable is physically severed in a trauma, or the system is actively attacked from within by an autoimmune disease, keeping a human being alive requires just an astonishing amount of engineering.
It really does. It's the ultimate medical tightrope walk.
Exactly. And that is the mission of today's deep dive. We are looking at clinical nursing protocols and medical texts covering spinal cord injuries, or SCI, and Guillain-Barre syndrome. We want to see how medical professionals keep the system alive when the communication highways are severed, right? And what this extreme engineering teaches us about our own biology.
Yeah, and to really grasp the interventions required for an SCI, we have to first kind of map out the physical geography of the
Right.
damage.
The geography of the spine.
Right. Think of the central nervous system as a master server. That's the brain. And it's connected to this massive, highly delicate trunk line running down your back.
So it's basically like a fiber optic cable.
Exactly like that. And just like a physical fiber optic cable, the higher up the line the cut happens, the more houses lose their signal.
Right, right. A difference of literally millimeters on the spine changes a person's entire physiological reality.
It does. So starting at the very top of the neck, we have the high cervical nerves, C1 through C4. Injuries up here are, well, they're the most devastating because they sever the signal to the diaphragm.
And the diaphragm is what pulls air into the lungs.
Exactly. Without that signal, a patient at C1 to C3 loses the ability to breathe on their own. They require continuous mechanical ventilation just to survive.
So they are totally physically dependent on 24-hour intensive care.
They are. But the clinical protocols for this specific group involve this incredible psychological intervention. Because they can't move from the neck down, the medical team trains them to become the director of care.
Wait, director of care, what does that actually mean in practice?
It's a profound shift in agency. The patient is taught to use, like voice-activated technology, to verbally run their own ICU.
Oh, wow.
Yeah, they learn the exact parameters of their ventilator, the precise schedule of their medications, and how to explicitly direct a caregiver to, say, clear a clogged airway.
So their ability to literally speak and command these procedures is the mechanism keeping them alive. That is intense.
It is. Now, moving just slightly down the cord to C5, the low cervical nerves, the biological picture shifts entirely. The signal to the diaphragm is intact.
Okay, so they can breathe on their own.
Right. And they regain control of their deltoids and biceps. They still can't control their hands or wrists, but they can bend their elbows.
Which means they can use adaptive equipment, right? Like those universal cuffs strapped to their arms to feed themselves.
Yes. But they face this hidden mechanical danger, which is pressure. Because they lack the triceps strength to push themselves up, they can't naturally relieve the pressure on their skin.
Because gravity becomes a constant threat.
Exactly. When you sit in one position, your body weight compresses the blood vessels in your skin against your bones. In a healthy system, your body senses that minor tissue starvation and automatically shifts your weight.
Like when you fidget in a chair.
Right. But without that sensory loop, the skin and tissue literally suffocate. They break down and form these massive necrotic pressure ulcers in just a matter of hours.
Oh my God, just from sitting still.
Yeah. So C5 patients have to be trained to purposefully lean side to side on a very strict schedule just to manually restore that blood flow.
Wow. Okay, so moving down further, as we track to the C8 level, the courses say we hit a huge transition point for independence.
Yes, C8 is where hand function begins to return. It allows for independent transfers, like moving from a bed to a wheelchair.
But wait, a patient at C8 still has really impaired fine motor coordination, right? They can't just consciously curl their fingers into a tight fist. So how do they actually grasp objects like a toothbrush or a fork to be independent?
This is fascinating. They use this brilliant manipulation of basic physics called the tenodesis grasp.
The tenodesis grasp.
Yeah, the clinical protocol actually teaches them to cheat the broken neurological system using the intact muscles they still have. If you are listening right now, hold your hand out, totally relaxed.
Okay, I'm doing it.
Now bend your wrist backward, pulling the back of your hand toward your forearm.
Oh, wow. Yeah, the moment I pull my wrist back, my fingers just automatically curl inward. I'm not even trying to close my hand.
Right, that tension just pulls them shut. That is the mechanical workaround. The tendons running down your forearm to your fingertips are fixed at a specific length.
So when you extend the wrist, you increase the distance those tendons have to cover.
Exactly, which naturally pulls the fingers into a curled, gripping position. Medical teams train C8 patients to use that automatic tension to lock their fingers around objects. They basically replace the lost neurological signal with raw mechanical leverage.
That is it's incredible
It
engineering.
really is. And then, finally, we reach the thoracic injuries, T6 through T12. This results in paraplegia. The arms and hands are fully functional, but the lower body is offline.
And the texts mention that T12 patients uniquely possess what the medical field calls cough power.
Yeah, a cough feels so simple to us, but it requires this forceful, coordinated contraction of the abdominal muscles to expel air and secretions out of the lungs.
And patients with higher cervical injuries lack that abdominal control, right? So they can't clear their own lungs.
Right. They basically drown in their own natural mucus, which puts them at massive risk for fatal pneumonia. But T12 patients have the trunk control required to generate that explosive outward pressure.
Okay, so everything we've mapped out so far, that's just the primary injury, the initial cut or physical trauma. But the sources highlight that the initial impact is actually just the beginning of the destruction.
Yeah, the body's own biological response creates this secondary wave of damage that can be far more catastrophic than the initial blow.
Because the mechanical damage is instantaneous and permanent. But then, in the minutes and weeks following the trauma, a biochemical cascade known as the secondary injury kicks in.
Right, and it involves three primary destroyers: ischemia, edema, and excitotoxicity. Ischemia is just the immediate lack of blood flow to the area. Edema is severe swelling.
But the spinal cord is encased in a rigid, bony tube, the spinal canal. So that swelling literally has nowhere to go.
Exactly. It expands outward and physically crushes the surviving nerves against the bone, like a tourniquet.
And then excitotoxicity acts as a kind of chemical poison, right?
Yeah, because when nerve cells are crushed and begin to die, they don't just fade away silently, they rupture. They vomit massive amounts of chemical messengers, like glutamate, into the surrounding tissue.
Wait, so the dying cells actually poison the healthy ones?
Yes. This chemical flood aggressively overstimulates the neighboring healthy nerve cells until they literally burn themselves out and die. It spreads the zone of destruction further up and down the cord.
That is wild. So the ultimate medical priority in those first crucial hours is saving what's called the penumbra.
At penumbra, yes. It's the perimeter of tissue surrounding the primary impact zone. The nerves there are stunned, they're crushed by edema, they're starving for oxygen, but they aren't dead yet.
And to save them, the medical team has to play this highly dangerous game with the patient's blood pressure. They target a mean arterial pressure, or MAP, of 85 to 90.
Which is very high. To put that into context, a normal, healthy person requires an MAP of roughly 65 or 70 to keep their organs adequately perfused with blood.
But a pressure of 70 just isn't strong enough to punch through the crushing edema in a damaged spinal cord?
Exactly. The critical care team has to use IV fluids and vasopressor medications to artificially crank the patient's baseline pressure up to that 85 or 90 range. They use raw hydrostatic force to shove oxygen-rich blood into the dying penumbra.
But that task is complicated by a weird physiological paradox. I mean, we're conditioned by movies to think that someone going into shock is going to be cold, pale, and clammy.
Right, the classic shock symptoms.
But these sources explicitly warn that a spinal cord injury can trigger neurogenic shock. The patient's blood pressure plummets to fatal levels, yet their skin is warm, dry, and flushed. Why does the body react the exact opposite way we expect?
It comes down to a complete failure of the sympathetic nervous system. In typical shock, say, from massive blood loss, the body panics. The brain sends a frantic sympathetic fight-or-flight signal to clamp down on all the peripheral blood vessels.
Shunting the blood to the vital organs.
Right. That intense vasoconstriction pulls warm blood away from the surface, making the skin cold and clammy. But in neurogenic shock, the spinal cord is severed, so that panic signal never actually reaches the body.
The central server is disconnected.
Exactly. Without that constant baseline sympathetic signal telling the blood vessels to maintain their tension, they experience massive vasodilation. The vessels just completely relax and open up.
Oh, so all of the body's warm blood pools uselessly at the surface of the skin.
Yes. The patient feels warm to the touch, they look pink and flushed, and it deceives the caregiver into thinking they're stable. Meanwhile, their internal plumbing has lost all of its resistance, and their blood pressure is in a deadly freefall.
The cardiovascular system has just completely lost its governor. Which leads us back to that terrifying scenario we opened with, the unmutable alarm. What happens when the internal alarm system short circuits? Autonomic dysreflexia, or AD?
AD is a massive, life-threatening emergency, primarily seen in injuries at the T6 level or above.
And the triggers are usually what the texts call the big three irritants below the level of injury: the bladder, the bowel, or the skin.
Right. A kinked urinary catheter, a severe bowel impaction, or even a tight belt or a wrinkled bedsheet.
But the patient cannot consciously feel the pain of that wrinkled bedsheet.
No, they can't. But their lower autonomic nervous system absolutely registers the distress, and it panics. It releases this massive surge of stress hormones, causing intense, violent vasoconstriction below the level of the injury.
Which drives the blood pressure to catastrophic stroke-inducing levels.
Yes, and this is where the severed cord becomes a lethal barrier. The high-pressure blood rushes up to the brain. Baroreceptors in the neck detect this critical pressure spike, and they scream at the brain to fix it.
So the brain immediately fires a parasympathetic signal down the spine, commanding the blood vessels to dilate and lower the pressure.
But that relaxation signal hits the physical roadblock of the spinal cord injury and bounces off.
It can't penetrate the damage.
Exactly. So below the injury, the blood vessels remain violently clamped down, driving the pressure higher. Above the injury, the brain's dilation signal actually does work, causing the blood vessels in the face and neck to swell massively.
Which causes that pounding headache and flushed face.
Right. And simultaneously, the brain desperately tries to lower the pressure by slowing the heart rate down, leading to severe bradycardia. It is a biological tug-of-war that will end in a stroke if not stopped.
The interventions are frantic. I mean, you have to find the irritant and remove it. But usually, if someone's heart rate drops and they are in distress, you lay them down. Why is the absolute first instruction here to set the patient straight up to a 90-degree angle?
You're basically using gravity as a fast-acting drug. Sitting them upright creates an immediate orthostatic effect. It's the fastest way to drop intracranial pressure.
Oh, because gravity pulls the blood down.
Right. Gravity pulls that massive volume of blood away from the brain, trapping it in the dilated vessels in the lower body. It buys you precious seconds to find the kinked catheter before a vessel in the brain bursts.
And if they can't find the trigger fast enough, they have to use rapid-acting vasodilators. But there is a massive life-or-death warning here. They have to check for recent use of sildenafil, commonly known as Viagra.
Yeah, both sildenafil and the emergency vasodilators work on the exact same chemical pathways. If combined, the synergy causes the blood pressure to crash completely. You'll put the patient into cardiac arrest.
Wow. And the texts also say that even searching for the trigger is dangerous. Like, if they suspect a bowel impaction, they have to use a topical anesthetic like lidocaine 10 to 15 minutes prior to checking.
Because if a nurse simply performs a manual disimpaction without numbing the area, the sudden, intense pain of the exam itself will send another massive distress signal up the cord.
Spiking the blood pressure even higher. It's just a minefield.
It really is.
So we've been focusing heavily on mechanical trauma, the hardware being physically cut. But the expert sources also shift into what happens when nervous systems breakdown isn't from a car crash, but an internal software virus, Gullian-Bare syndrome, or GBS.
GBS is terrifying because the biological infrastructure is fully intact, but the body's own defense mechanisms turn against it. It's an inflammatory demyelinating disease.
And it usually starts with a biological misunderstanding, right? Molecular mimicry.
Exactly. A patient will contract a standard viral or bacterial infection. The immune system generates antibodies to hunt down that specific pathogen. But in GBS, the proteins on the surface of the virus closely resemble the proteins on the myelin sheath.
The myelin sheath being the protective insulation wrapping our peripheral nerves.
Right, so the immune system gets confused, and it begins systematically eating away the insulation on its own electrical wires. The wire itself is still there, but without the myelin, the nerve signal sparks out, slows down, and eventually fails.
It's like an electrical wire's insulation being slowly dissolved. And the disease progresses through three distinct phases.
The first is the acute phase. It's marked by an ascending paralysis. It starts as tingling and weakness in the feet and steadily migrates upward through the legs, the trunk, and the arms.
And the biggest danger here is when it hits the diaphragm. Caregivers have to constantly watch the patient's vital capacity, the volume of air they can exhale. If it drops below 15 milliliters per kilogram, it means the respiratory muscles are failing.
And they require immediate intubation, which leads into the plateau phase. This is arguably the most psychologically harrowing experience a human can endure.
Because the autoimmune attack stops, but the damage is done.
Yes, the patient is locked in a static state of paralysis, fully conscious, feeling everything, but entirely trapped inside a body that refuses to move.
And the level of invisible preventative care required here is immense. I mean, nurses have to implement DVT prophylaxis to prevent blood clots from pooling in their immobile legs and traveling to the lungs.
Compression boots, blood thinners, communication boards where patients spell words by blinking. It's intense.
But here is a really counterintuitive part. The texts mention autonomic instability during this phase. If the patient's blood pressure becomes wildly unstable, swinging from extreme high to extreme low, the sources say we shouldn't aggressively treat the high blood pressure with drugs. Why?
Because the body's compensatory mechanisms are broken. If a nurse pushes a powerful drug to drop a high blood pressure spike, the damaged autonomic system cannot catch itself on the way down.
Oh, so the pressure won't just normalize, it'll completely bottom out.
Exactly. It'll throw the patient into shock. You essentially have to sit on your hands and ride out the biological storm without overreacting.
That sounds incredibly stressful for the medical team, but eventually they enter the recovery phase.
Yes, descending remyelination. The return of function happens from head to toe, and treatments to speed this up include plasmapheresis and IVIG.
Plasmapheresis physically filters the blood, washing away the rogue antibodies, and IVIG is intravenous immunoglobulin. You flood the system with healthy donor antibodies to overwhelm the rogue cells with decoy targets.
Right. It's basically targeted biological warfare.
It's amazing. And managing both SCI and GBS requires highly specific diagnostic tools and physical engineering. And each comes with bizarre rules, like a lumbar puncture for diagnosing GBS.
Yeah, they insert a needle into the spine to draw out cerebrospinal fluid. The post-procedure rule is ironclad. The patient must lie completely flat for 4 to 8 hours.
Because if they sit up, gravity pulls the fluid out through the puncture hole. It creates a literal vacuum inside the skull, pulling the brain downward and causing a massive spinal headache.
Exactly. Or consider the EMG, where fine needles are inserted into the muscle. The strictest rule.
Yep.
No lotions or creams on the skin.
Because the oil acts as an insulator, blocking the electrical signals. And during nerve conduction studies, they literally have to keep the patient's limbs warm. It sounds like a spot treatment, but if the tissue is cold, it physically slows down the nerve transmission.
Right. A cold limb will show a sluggish signal, leading to a completely false diagnosis of nerve damage. The physical devices used are equally intense. Think about the halo vest.
Right, a metal ring bolted to the skull to immobilize the neck.
The primary safety protocol requires a specific emergency wrench to be taped directly to the chest piece at all times. Because if the patient goes into cardiac arrest, you cannot perform chest compressions through that hard plastic.
You literally have seconds to use the wrench to pop the front plate off.
Wow. And then there's the rotores bed.
Yeah.
It continuously spins a paralyzed patient side to side at a 40-degree angle. I mean, are we just slowly spinning patients to keep them entertained?
No, it serves a critical function called pulmonary toilet.
Pulmonary toilet. Yeah. When you cannot cough, the lungs act like sponges sitting in a puddle. They fill with fluid, bacteria multiply, and pneumonia sets in. The constant extreme rotation of the bed uses gravity to physically slosh the mucus around.
Mobilizing the secretions and keeping the lungs clear without muscle power, it's brilliant.
The pharmacological balancing act is just as extreme. Take solumedrol, a massive dose of corticosteroids given for acute spinal cord injuries. It follows a strict 8-hour rule.
It has to be given within 8 hours of the trauma to aggressively reduce that deadly edema in the penumbra. But the cure comes with severe risks.
Yeah, it shuts down the immune system, skyrockets blood sugar, causing steroid-induced diabetes, and drastically increases the risk of massive GI bleeding. You're constantly weighing the benefit of saving spinal tissue against the immediate bodily harm of the side effects.
Every single diagnostic, every physical rotation of a bed, every calculated drop of medication, it's all an attempt to artificially replicate what the healthy nervous system does effortlessly in the background.
Every single second of our lives.
The sheer volume of invisible work our bodies execute is just staggering. From pressurizing our blood vessels to the complex mechanics of a simple cough, the interventions really highlight the fragile brilliance of human anatomy.
Absolutely.
So as we wrap up, if you are listening to this right now, take a moment, take a deep breath, and feel your chest expand. Flex your hand into a tight fist. Notice the temperature of the air on your skin. And just appreciate the flawless, high-speed biological network inside you, making all of that possible completely automatically.
It is a profound piece of machinery.
Yeah.
And to leave you with one final concept to chew on, Guillain-Barré syndrome proves that the peripheral nervous system can completely remyelinate and rebuild its pathways.
From the top down.
Right. A patient can be fully paralyzed on a ventilator,
Yeah.
and months later walk out of the hospital as their peripheral nerves regenerate.
Mm.
If the peripheral system can do that, what does that imply for the future of central nervous system injuries?
Oh, wow.
Could we one day decode those biochemical signals and trick a severed spinal cord into repairing itself the exact same way?
That is the ultimate frontier of medical science. And an incredible thought to end on. Thank you for joining us on this deep dive. Keep asking questions, keep exploring, and we will see you next time.